Okay, I think we're missing Dr. Bernard from Belize. But I think we'll go ahead and begin, given that we have a very tight schedule. So a very good afternoon to you all, and welcome to this event, No Time to Wait, Resilience as a Cornerstone for Primary Health Care across Latin America and the Caribbean, and the launch of the report to the World Bank, PAHO, the Lancet Regional Health Americas Commission, on the same subject. My name is James Fitzgerald. I'm the Director of the Department of Health Systems and Service. I'll be your moderator for the session this afternoon. Before we begin, I would like to announce that we have simultaneous translation available, so please feel free to use that service. We do have a full and engaging agenda for our event today with some excellent presenters and speakers. Our time is actually limited, so as one of my roles as moderator will be to ensure that we guide you through the process, guide you through the event, and I do ask all presenters and speakers to see if we can keep to the time, as we need to be back in the room for 2:30. Let me recognize our head table, Dr. Jarbas Barbosa, the Director of the Pan American Health Organization, Dr. Jimena Aguilera, the Minister for Health of Chile, Dr. Kevin Bernard, Minister for Health of Belize, Dr. Eritzel Santa Maria, the Deputy Director and National Director of Planning for the Ministry of Health of Panama, and Dr. Jaime Savreda, the Director of Human Development for Latin America and the Caribbean at the World Bank. We also have connected this afternoon Dr. Adriano Massudo, who's the Vice Minister of Health in Brazil, as well as many important members of the World Bank PAHO Lancet Americas Commission, who have been responsible for this wonderful work that we'll be presenting for you this afternoon. We do have some of our esteemed commissioners here as well this afternoon. Dr. Sarah Bennett from Johns Hopkins University, the Bloomberg School of Public Health, and Dr. Marcia de Castro, the Global Health and Population from Harvard T.H. Chan School of Public Health. And of course, our co-chairs for the Commission, economist Christian Herrera from the World Bank and Dr. Ernesto Bascolo from the Pan American Health Organization. Let me also recognize Dr. Thaisa Vila, the Editor-in-Chief at the Lancet Regional Health of the Americas, sitting here beside me, and thank you, Thaisa, for all the hard work you've done to get us here today. So with that, let me invite Dr. Barbosa to open the event for us. Thank you very much.
Thank you, James. Good afternoon. Honorables ministras.
Honorable health ministers, official delegates of the member states of the Pan American Health Organization, members of the Lancet Regional Health Americas Commission, partners, colleagues. It's an honor for me to be with you here for the launch of this report, No Time to Wait, Resilience as a Cornerstone for Primary Health Care across Latin America. This report was drafted together with the World Bank, the Pan American Health Organization, and the Regional Health Americas Commission of the Lancet. Comes at an urgent time. Our region is one of the most hard hit by crises in the world, different pandemics and impacts and everything that comes with climate change are not the exception. They are the rule. That said, too often, our healthcare systems, and in particular primary healthcare, have not been prepared to protect those whom we serve. The COVID-19 pandemic laid bare this vulnerability in a very clear way. Throughout the region, essential services were affected for maternal care, vaccination of children, chronic diseases, and others. Whole families lost access to care when they most needed this care. This can never happen again. Not during the next pandemic or emergency or any crisis that we are called upon to tackle. Without primary health care, strengthening it as a key pillar of the resilient healthcare systems we strive for, the cost of inaction will be huge. The human cost is devastating. Thousands of mothers and children will die, preventable deaths, neonatals as well, 100,000 additional deaths caused by non-communicable diseases, millions of unplanned pregnancies. The forecasts by the Commission say that one shock with a 20-25% drop in the coverage of first level of care services and a recovery that could take between 1 and 5 years would have an estimated cost of between $7 and $37 billion. Each one of these figures represent mothers, children, families throughout our region whose lives are in jeopardy. Now, the healthcare systems in the Americas continue to be fragmented in how they organize healthcare services, focused too much on hospital care with sufficient investment in primary healthcare being made. This mismatch leads to systemic inefficiencies that are quite pronounced and disparities in how health is delivered. It's always the most vulnerable, indigenous peoples, Afro-descendant peoples, rural communities who bear the brunt of this.
This is why resilience must become a political priority. Resilience is not a luxury. It is a foundation of health security, social stability, and economic growth. Failing to strengthen our primary healthcare system will inevitably cause the next crisis to disproportionately harm our poorest and most vulnerable communities. A resilient primary healthcare ensures the continuous provision of essential services, prevention, treatment, and care before, during, and after shocks. The good news is that we know what works. The Commission calls for reanchoring health system in strong primary health care, where prevention, continuity, and community trust build resilience. It urges to close financing gaps with sustainable investment, align resources to primary health care networks, advance reforms that reward quality and people-centered care, strengthen governance and community participation, and build a resilient health workforce with adequate numbers, decent conditions, training, and digital tools to reach every community. Colleagues, the message is clear. There is no trade-off between building stronger primary health care and building health systems resilience. They are synergistic and mutually reinforcing. Investing in resilient primary health care is not only a health imperative, it is also a political and economic necessity for stable, healthy communities. History shows that Latin America and the Caribbean is capable of enacting bold reforms and innovation. Today, we must summon the semi-political will. Let us commit to making resilience a cornerstone of primary health care to ensure the people of this region are protected by strong, continuous, and sustainable essential services through any future crisis. The cost of inaction is measured not only in billions of dollars, but also in lives lost. Investing in our people, economies, and future is the only viable path forward. Distinguished delegates and colleagues, the title of this report says it best. There is no time to wait. The time to act is now. Thank you for your attention.
Thank you very much, Dr. Barbosa, for those opening remarks. Now let me pass the floor over to Dr. Jaime Savreda for some opening remarks from the World Bank. Thank you.
Oh, thank you very much, James. Good afternoon to everyone. I would like to start by greeting everyone gathered here, ministers of health, members of the Directing Council, and distinguished delegates. And here in the table, Dr. Jarbas Barbosa, Minister Aguilera, from Chile, Minister Bernard from Belize, Dr. Eritzel Santamaria from Panama, and also want to say hello to Thais Avila, Editor-in-Chief, who has been partner in crime during the last 2 years in this endeavor that we're talking about today. I want to also agree the co-chairs and all the commissioners who made this report possible. And it's an honor for the World Bank to join the Pan American Health Organization and the launching and the Lancet in launching this Lancet Commission report focused on primary healthcare resilience. As Dr. Barbosa was saying, Latin America and the Caribbean is in the path of many shocks. And unfortunately, despite that, our systems are still built around hospitals instead of resilient primary healthcare. COVID-19, the pandemic, exposed that weakness. With 8.5% of the population, of the world's population, we accounted for roughly 13% of cases and 30% of deaths. In many countries, essential services like maternal and newborn care, immunization, chronic disease management fell by between 20 and 50% for at least 2 years. And this, as Harbas was hinting at, this cannot happen again. We need to prioritize primary health care, and as the report underscores, we must ensure that we invest in community-based teams, that we have reliable supply chains, digital tools, and a trained workforce ready for emergencies. The urgency to do this is both to improve the quality of care and also to be better prepared for any future shocks. The Commission asked the question, what if we do not do what we need to do, right? And the Commission tried to answer this question by modeling precisely the cost of inaction, right? And as it was said, a short shock could imply losses of about $14 billion. A shock that lasts longer, up to 5 years, could push the losses to about $35 billion, nearly 1% of GDP. And even those conservative figures translate into thousands of preventable deaths. So the question that we need to ask ourselves is, are we doing enough in Latin America and the Caribbean? And the answer, I would say, is not yet. Our region invests around 70.5% of GDP on average on current health expenditures, well below the average of OECD, which is 13%. And there is a wide variation within our region, from 3% in some cases to 12% in other cases. But in all cases, the issue is not simply how much we spend, but how we spend. Stronger primary health care and greater resilience are two sides of the same coin. And there are many things that we need to do in order to spend better. But I want to mention two things. The first one area that I need to mention is investing in people. Despite scientific progress, despite artificial intelligence, healthcare is intensive in human interaction. A robust health workforce is the backbone of high-quality primary healthcare. Yet many Latin American and Caribbean countries face shortages and maldistribution of health professionals in primary healthcare. Most of our countries lack sufficient primary care providers, especially outside urban centers. So investing in human health resources is absolutely critical. We need to care about the people who deliver the care. Investing in hiring, in supporting, providing professional development opportunities and incentives, using multidisciplinary teams, and deploying efficiently and equitably health professionals. That is a massive and urgent challenge in many countries. And the second point I wanted to mention is that we need to invest better on digital health. The report reminds us that digital tools are now essential for care delivery, but their use must account for the vast digital inequities in our region. However, we know that used wisely, digital tools transform resilience. To give one example, Panama's telesalud program expanded consistently between 2021 and 2024. In Sao Paulo, Avanza Saúde unified clinical data for 26 million people and logged 1.7 million teleconsultations. Costa Rica's digital health record now covers 90% of primary health care facilities. These are not pilots. These are initiatives that show that digital health, when done right, strengthens primary care and resilience. And this is just one example. The Commission's findings go well beyond technology. They call for PHC systems that integrate public health functions, empower communities, and secure sustainable financing. Just to conclude, strengthening primary health care is one of the greatest health challenges in Latin America and the Caribbean. The Commission's report is a roadmap that shows what works. But the hardest part is not technical. The hardest part is political. is the need for governments to place primary healthcare at the center of their agendas, invest in it urgently and at scale, and ensure universal coverage. Protecting lives and economies cannot be optional. It must be a priority, and there's no time to wait. Thank you very much.
Thank you very much, Dr. Saveredo, for those words. Now let me pass over to Dr. Thaisa Villa from the Lancet Health Americas.
Thank you, James. Distinguished guests, colleagues, thank you for the opportunity for us to launch it here. I would like to greet Dr. Jarmus Barbosa for being here, Dr. Saavedra, Minister Aguilera, Minister Bernard, and Dr. Santamaria, and I was just going to give some remarks from our side. It is a privilege to open the launch of this Commission report that was led by PAHO and the World Bank, and also a group of outstanding academic researchers from the region. As an editor-in-chief, I'm honored to witness our journal's first commission coming to life. A Lancet Commission is traditionally set out not to describe the world as it is, but to challenge the status quo and to ignite real and lasting change. And I expect nothing less from this one. The Commission stands out as a multidimensional approach, and it brings together academic analysis, community voices, practical implementation experience, and expertise in health and financing. In times like what we are living now, when the work of multilateral entities is being questioned and the value of international collaboration is under scrutiny, it is essential to highlight the power of multilateral approaches, as we're doing right now today. This Commission is a proof that when we work together across borders, across disciplines, we can produce solutions that are both ambitious, but also grounded on the realities of each country and each region. It is also clear from the report that the ultimate goal continues to be a universal, free, and people-centered healthcare that is also resilient to shocks. It is not enough to just expand coverage in abstract. We must ensure that every person, regardless of income, geography, ethnicity, gender, or migration status, can access the care that they need when and where they need it without financial hardship. Our region, as my colleagues just said, is extremely prone to shocks, and we are not prepared for them. And the resilience primary healthcare is the only foundation of healthcare systems that can withstand the shocks, protect the lives, and promote equity, as we all want. But what's perhaps the most important point of this report is that every recommendation that you will read here is grounded in rigorous scientific research. And again, when science is sidelined and politicized, it's vital that we continue to let evidence guide our decisions. The expectation of a Lancet Commission, as you can imagine, is high. And we hope that this report can guide government, civil society, scientific communities, and move beyond the rhetoric to take concrete steps to build a resilient, equitable, and people-centered primary healthcare. I also hope that it will set a new standard for when we approach complex health challenges by bringing together diverse expertise, centering the voices on those that are most affected, and insisting on accountability and transparency at every stage. And the work doesn't end here. It actually starts today. This report is the beginning of a long path to a truly transformational reform of our health systems. Our job will be to support, monitor, and continue to report the progress, share the hardships, and learn from each other as countries, as entities, and as a journal. But before I close, I would like to acknowledge the extraordinary team behind this work that we're here from today. My deepest thanks to Christian and to Ernesto for the leadership to all the commissioners for the rich and challenging discussions, to the entire authorship team for the commitment and collaboration for over 2 years of work, and also for the consultants and the secretariat that took all of these discussions, all our ideas, all of this continuous conversation, and put it into a very nice wording that you can hear today and read in the report. So this report is actually a testament that we can achieve a lot when we work together across the disciplines, sectors, and borders. We owe to these people here that the recommendations in this commission do not remain words on a page, but they become the foundation for a more just and resilient future for all of us in the region. It is an honor for the Lancet Regional Health Americas to host and support this work in our pages. Thank you.
Thank you very much, Dr. Villa, for those remarks. I want to thank all the speakers for their opening remarks. We'll now actually move to a short video of the Commission. As you know, PAHO, the World Bank, and the Lancet Commission was actually launched in January 2024 to develop a comprehensive conceptual policy framework for primary health care and resilience, and to identify fundamental strategies and policies to develop and define the key investments that LAC countries could carry out. So with that, please, can we have the video to present the process and some of the initial findings? Thank you.
In Latin America and the Caribbean, health faces an increasing number of threats such as climate change, epidemics, as well as demographic and epidemiological transitions. How do we bring together science, public policy, and financing to respond to these challenges? In January 2024, the Lancet Regional Americas Commission on Primary Healthcare and Resilience was established, an alliance between the World Bank, the Pan American Health Organization, and the Lancet Regional Health Americas. The mission of the Commission, comprising of experts from the region, is to generate practical evidence and issue a call to action to transform health systems based on primary healthcare and strengthen resilience to potential new epidemics, climate change, and natural disasters.
Esta comisión viene a recolocar la importancia de la atención primaria en salud en una región que ha tenido una larga trayectoria y que requiere su fortalecimiento y el apoyo político y de las comunidades para hacer una realidad.
The Commission estimates that a crisis reducing primary healthcare coverage by 25 to 50%, with a recovery period of 1 to 5 years, would impose an economic cost on the region ranging from $7 billion to more than $37 billion. The more conservative estimates indicate that such a disruption could cause over 165,000 additional deaths in the region.
Esta comisión pues es una gran oportunidad para poder llenar ese bache que hay en el conocimiento y poder dar recomendaciones que sean de utilidad para los países para tener un mejor sistema de salud.
Resilience requires sustained action in prevention, preparedness, response, and recovery. Therefore, the Commission recommends integrated and equitable models of care, strengthening essential public health functions, community participation and trust, multi-sectoral policies with public-private collaboration, and sustainable and flexible financing.
A commission like this is very important because it brings together individuals who have been working in the health team for a long while, have a different kinds of expertise and experience from different countries in the Americas to look at how can we better improve primary health care.
Additionally, through the Regional Alliance for Primary Healthcare, the Pan American Health Organization, the Inter-American Development Bank, and the World Bank are promoting investment and innovation to achieve more robust and sustainable primary healthcare. Strengthening primary healthcare and resilience are mutually reinforcing. Investing in resilient health systems based on primary healthcare is urgent to save lives and protect the future economy. There is no time to wait.
At the launch of the Commission, President Bachelet, former President of Chile, and the former UN High Commissioner for Human Rights congratulated the initiative of the Commission that addresses issues of great political, economic, and social relevance, bringing people together through commissioners with great levels of expertise around these issues. And so now let me introduce some of our commissioners to you that are here today that will present some of the findings for us. Dr. Sarah Bennett from Johns Hopkins University Bloomberg School of Public Health will deliver a short first presentation, and then followed by Dr. Marcia de Castro, Global Health Population from the Harvard School of Public Health. We'll follow that presentation from Dr. Bennett. And then we'll have a comment from Dr. Javier Guzman, the Division Chief Health, Nutrition, Population at the Inter-American Development Bank, around the findings of the report. So Sarah, over to you.
Thank you very much indeed, James, and good afternoon, honourable ministers and other distinguished delegates. It's a real privilege and truly exciting to be here this afternoon, given all the work that has gone into this report. I'm not sure if I can control the slides, or if you can just pass the... Thank you. Doesn't seem to work. Oh, here we go. Obviously, a large report like this takes a village to create it. So I wanted to very briefly introduce to you the chairs of the Commission, as you can see set out here, and also some of the commissioners, and really to underscore that this was a large effort that depended upon a large and diverse community of people representing indigenous populations, civil society organizations, governments, and obviously international organizations as well, all of whom contributed extensively to the report. The aim of the report is really to advance knowledge and inform decision-making for the future development of resilient primary health care, which you've already heard about. And we set out 3 different objectives for the report. Firstly, to develop a comprehensive policy framework for primary health care resilience. Secondly, to assess the potential consequences of not building resilience into primary health care. And you've already seen some of the findings from that section of the report presented in the brief video, where we talked about the economic costs if greater resilience was not built. And then thirdly, to identify potential strategies and policies that countries could pursue in order to improve resilience for future shocks. And we're going to spend much of our brief presentation today focused on this third of the objectives. So this just gives you an overview of the report structure, and really to describe where we're focusing in on, we're really talking about parts 3 and 4 of the report, which present the resiliency framework and policy recommendations, and also begin to set a path forward towards implementation. So starting with the conceptual framework that was used to guide the thinking of the Commission, many of the literature reviews that we did, and the recommendations that came from the Commission. If you look at the center of this figure, you can see that we reflect on 4 phases of health systems resilience. And this is a commonly used framework that looks firstly at issues around prevention and preparedness. How can we prepare for possible shocks, whether these are shocks in terms of climate, shocks in terms of disease outbreak, or natural disasters? And in some cases, are we able to prevent those shocks actually occurring, especially if we're talking about disease outbreaks? Moving around to the next stage of resiliency, we need to think about shocks and our immediate response to these. And so what happens once a shock is detected? How do we communicate that that is occurring to the key stakeholders within the community? And then over time, as we respond to that shock, we need to think about our responsiveness, how we adapt health systems, particularly primary healthcare systems, to continue to provide essential health services throughout the course of the shock, but also how do we contain the shock if possible, so responding to the sources of risk, whether again that's to do with disease outbreaks, where we are looking at essential public health functions, how to ramp up surveillance, and how to communicate to diverse stakeholders. Then the final, and I think often neglected stage of this resiliency cycle is really around recovery and learning. And what we're truly hoping to do here is to build back better. So how can we learn from the shock and make sure that the health systems and primary healthcare in particular grows stronger as we learn about what worked, what didn't work in response to this. So we took these 4 phases of health systems resilience as our core and then reflected on how this connected to primary healthcare. And we used the WHO framework that really identifies these 3 pillars around primary healthcare. So first is around integrated health service delivery, and we included within that the essential public health functions. So there's core public health functions that need to be delivered to sustain the public's health. The second domain that we looked at was around community empowerment and participation, reflecting that to be successful in responding to any shocks, we really need to work closely with the community, have a deep understanding of the community response to the shock. And then the third domain that we looked at was around multi-sectoral coordination and response, knowing that many of these shocks are not just shocks that affect the health sector, but ripple throughout the economy, affect education, and affect other sectors as well. So this is the core of the report, but we also acknowledge that primary healthcare systems exist as part of an integrated, broader health system. And so we also wanted to look at how that broader health system is financed, the nature of information and data used for decision-making, and other inputs that may be relevant. And then finally, around all of this, we acknowledged the political environment, the institutions that help support primary healthcare, and the broader socioeconomic context that may influence how primary healthcare responds. And obviously all of this needs to come together for our ultimate goal of ensuring universal and equitable health access and coverage that promotes and protects health and fosters a stronger economy at the same time. So just to give you an idea about the sort of 4 buckets, if you will, of recommendations that this report sets forward, and which links very closely to the conceptual framework that I've just set out. So in the report, you'll see that our recommendations are aligned around these 4 themes. 1, around integrated service delivery and essential public health functions. Secondly, around community participation and empowerment. And thirdly, around multi-sectoral action. And then we also felt that issues around financing of primary healthcare and health systems, particularly during shocks, was so critical that we wanted to look at that separately. So these are the 4 domains which our recommendations are clustered into. I'm going to talk about the first 2 of these domains and then hand over to my colleague Marcia to talk about the remaining domains and moving forward with implementation. So the first domain looks at integrated service delivery and the essential public health functions. And we divided our recommendations here into 4 main areas. The first is about models of primary care that provide services for all. And we reflected that we really need to have primary healthcare models which are resilient to shocks, and that to do this, we encouraged countries to think about empanelment and linking primary healthcare facilities to enumerated populations. And that means you can then identify who are the vulnerable populations, who may be particularly at risk during a shock, and that also we needed to have interprofessional teams working at this level who can provide not just healthcare services, but who can connect clients to other sorts of services, whether those are social services or other types of required needs. Also, we think that this sort of integrated, close to the community model of primary care provides a basis for community outreach. So we're reaching out to communities to understand how they are experiencing shocks and to prioritize different aspects of the response. And as part of this, we also encourage governments to look at quality improvement mechanisms at this level and ways of understanding users' perspectives on primary healthcare and how the quality of care can be strengthened. The second domain that we looked at in this broad area is around integrated essential public health functions and primary care, recognizing that during COVID-19, in many cases, countries did not fully leverage their primary healthcare systems in order to be able to deliver essential public health functions. So we asked, how can we better bring together primary healthcare services and essential public health functions? And we suggested that in order to do this, we need to better train primary healthcare workers so that they can use data, analyze data and respond to the kinds of issues that they are seeing emerging within their communities. We also suggested that primary healthcare teams needed stronger epidemiological support, particularly in the domains of surveillance. And we looked at examples from Rio de Janeiro, where there was a very purposeful effort to bring together primary healthcare teams and epidemiological surveillance so that primary healthcare teams can help really identify shocks and respond to them. We suggested that there need to be greater efforts to engage communities into health assessments and strong health education programs from the primary healthcare level that really build communication strategies around shocks that are sensitive to the local population. We needed also, the third domain is around maintaining essential healthcare services during shocks. So what can be done to build resilience in the primary healthcare system so that services continue during a shock? And for this, we talk about the importance of digital health and also making sure that primary healthcare workers are trained in terms of how to manage patient flows during an outbreak or similar. The fourth domain in this area really speaks to the link between primary healthcare and higher level specialized networks, knowing that primary healthcare alone is never going to be sufficient in itself to respond to all of the healthcare challenges. So we argue that there needs to be really strong support from higher levels of the healthcare system in order to ensure strong care at the primary level and appropriate referrals level systems between different levels. The second bucket of recommendations speak to community participation and empowerment. And in this area, we have three different domains highlighted. One around community engagement, the second around interculturality, and the third around communications and trust. In the first domain, we recognize that to have a successful response to any of the types of shocks the report talks about, we really need to ensure that there is a reliable, trusted relationship between communities and primary healthcare. And so we talk about things like creating regular dialogues, planning opportunities between the communities and primary healthcare providers, ensuring that there are legal frameworks that require participation from the communities in terms of planning for shocks, as well as in terms of oversight mechanisms, and training primary care managers in community engagement activities. Secondly, in terms of interculturality, we reflected on how diverse the cultures within the region are and the need to really build healthcare services and community engagement strategies that are responsive to those diverse communities, whether we're talking about indigenous populations or LGBTQ populations. So in this regard, we talked about developing intercultural health policies that promote traditional medicine, financing intercultural primary care services, and a variety of other recommendations that you can see here. Finally, in terms of building communication and trust, we suggest that health managers co-create with communities sort of trusted communication strategies, and that we develop culturally appropriate multilingual health communications materials. So really thinking about how communication strategies can help build trust and bring the community in. Let me hand over to my colleague Marcia to walk us through the rest of the report.
Thanks, Sarah. Good afternoon, everyone. Dr. Fitzgerald, I'm mindful of time, so I'm going to go really fast. So the third bucket, as Sarah mentioned, is about multi-sectoral action. So here, what we discuss is the need to bring different sectors of the government. Just to name a few, it's health working with education, with social assistance, with security, with environment, and so on. But also the public-private partnerships. It's the use of data, so you can do risk mapping, you can identify geographies and population groups that are under higher vulnerability, and that enables actions to be targeted and directed to those groups. And this multi-sectoral action discussion also explicitly make connections with climate change, talking about climate resilient actions, but also health systems that are more sustainable and more environmentally friendly. We talk a lot about regulation, how oversight is going to be done of those collaborations, so the need for accountability, and also the need to link data from different sources as well. The last one is about financing, and here the whole discussion is how can we have the right mechanisms and legislation that enables the resources to be available when you have the emergency, but that they can also be disbursed quickly, promptly, and in a way that is accountable and transparent. We discussed the need to have different sources of funding, but also different suppliers, so you don't depend only on one person when you have to do procurement and purchasing of supplies. We talk about the need to find ways of reallocating resources, also including across different sectors in the government. We also framed this discussion that it goes through the entire resilience cycle. So it's the planning, it's the response, but also the recovery. One thing that is important to mention is that there should also be mechanisms to fund actions that come from the community, and that connects to the other bucket that Sarah mentioned before. So in the report, we recognize that some of those recommendations are very feasible for some countries in Latin America, but not so much for others. Some countries still need to build the essential public health functions before they can think about resilience. So we have this discussion, but recognizing that, we highlight a few things that have to be considered when we're thinking about resilience of primary care. First and foremost, the political economy of the region and of the countries. And when we talk about primary health care reforms, they are political. So you have political interests, you have the health demands, and as long as those are aligned in thinking about an agenda that focuses on equity, so you don't leave anybody behind and you don't perpetuate inequalities that the country has. We talk about the importance of having unions, and that can move forward some of the reforms as well, and what we call the political champions, people that can advocate for resilience at all levels of decision-making, from the very local all the way up to national and international. When we talk about implementation per se, we discuss the importance of having pilots. And by doing pilots, you're learning, you're adapting, you're fine-tuning, and you're creating this phenomenal laboratory of successful experiences that then can be used to share knowledge, to share innovation. Digital health is here as well. So when we talk about implementation, technology is here, but keep in mind that we need more than technology. We need commitment and leadership. Then on diagnosing, monitoring, and evaluation, we highlight the fact that we do not have a mechanism of diagnosing, monitoring, and evaluating the movement towards primary care resilience. And then we hope that the development of some indicators that are standardized and using data available across countries can help us to make a step forward on this. And the very last thing quickly is that the regional collaboration is an essential action to help move towards resilience, because there is peer learning, there is sharing experiences and sharing innovation. And the very last thing we're going to mention is that we talk a lot about recommendations for resilience of primary care, but we also highlight a few prerequisites to ensure that you have a primary health care that is really functioning. They relate to what we discussed before. So the very first thing is you need to have financing, robust financing that is mostly public and that is sustainable. In thinking about the health workforce, you need to have enough health workforce, well distributed and well trained. In thinking about supplies and inputs, you should not just have them, but be able to distribute them across the primary healthcare facilities. And most importantly, you need a strong and committed governance that makes decisions based on science, and that can coordinate across different levels of decision-making, but also across different sectors. So that was a very quick overview. There is much more to digest. The QR code was there. So as Thaisa said, we hope that this is just the end of the writing. Now that it's published, it's the beginning of the discussions across and between countries. So hopefully we can make some steps towards resilience primary care. Thank you.
Thank you so much, Marcia and Sarah. And as Marcia indicated, the report is really quite extensive. And so the QR code is actually there if you want to access the full report. It's available for you right now. Javier, let me hand over to you for some comments.
Thank you very much, James. Colleagues and excellencies and partners, first of all, let me begin by congratulating the commissioners, the Commission, our colleagues from the World Bank, from the Pan American Health Organization, and the Lancet of the Americas. It's clearly a landmark report, and it makes a compelling case that resilience and primary health care are inseparable. And we're not talking about, you need to have a trade-off and decide what to do. And we also very much appreciate that action is based on a very strong business case. So we're not talking about just saving billions, but we're also talking about saving livelihoods, which is the reason for us to exist. So bringing together evidence and analysis and linking that relationship between how resilience must be at the core of primary health care, but conversely, how primary health care is essential for resilience is, I think, very important. And also the how, because this is not just a framework for action, it includes clear, actionable recommendations. And in that how, I wanted to reflect on 4 specific topics. The first one is, when talking about resilience, we're talking about the system and the entry is primary healthcare, but it doesn't end in primary healthcare. And we saw how during COVID, primary healthcare was the point of entry, or wasn't the point of entry to the entire health system and broadly to the response society should have. So that is the first one. The second one, we think, it's important to look at resilience in the context of outbreaks, pandemics, emergencies, but clearly not only in those contexts. And we'll be, facing other important challenges that will require resilience within the health system. We've heard about migration, we've heard about human resources, we've heard about all other reasons why primary health care must be resilient. And it's important to take that into account. The third thing I want to say is the report highlights very nicely a lot of tools, digital tools that are important. And we believe at the Inter-American Development Bank that digital transformation is essential because the digital infrastructure is the connective issue we have within health systems. And we need to have that connective issue in the best possible way. That is why we are very pleased to be working with you, with the Pan American Health Organization and other partners in the Pan American Digital Highway, which is basically a very interesting concept that resembles, the commitment made by countries here to link the continent from north to south, but in digital infrastructure. So we believe investments in digital transformation are essential for resilience in primary health care to take place. And last but not least, I just wanted to say how financing underpins this work and how we, multilateral development banks, are ready to support countries, work with countries, and work with partners to make this report a reality and to translate recommendations into policies and into a more resilient primary health care. Thank you very much.
Thank you so much, Javier. Thank you so much, Javier, for those thoughtful remarks. Let me now return to the head table. First of all, I'd like to recognize our Assistant Director, Dr. Celie Thomas, who is now joining us at the head table. What we're going to do is we're going to have an interactive discussion now with some of our distinguished members of the head table. We're going to present some questions, some comments around the report, and ask for short interventions, 3 to 4 minutes each, so that possibly we can have 2 rounds of interventions from I suppose, our ministers and public health officials that are living the day-to-day experience of particularly what happened during the pandemic, but more broadly in terms of building health systems based on primary health care. Primero, me gustaría...
Let me begin with asking a question of the Minister of Health of Chile, Jimena Aguilera. Minister, Chile has advanced with a decision towards universal primary health care since the beginning of this administration. How can this process strengthen resilience so it's not only guaranteeing access and care in permanent times, but also how they can react when there are medical emergencies and other crises? Thank you for the invitation, for participating at the panel and the question. For us, primary health care is the principal key link of the health response. And this is what we have tried to put at the center of this policy for universal primary health care, recognizing also the PHC in Chile was given to the municipalities over 40 years ago. And this calls upon another element that I haven't heard mentioned, which is democracy. The fact that primary health care depends on an elect authority. They are elected by citizens. And this authority, recognizing the main problems in their community, will show health as one of the problems for the community, and this is a value added. Another element is that primary health care is provided by the municipal authorities in our country. This is the preferential place for the intersectoral action that has been mentioned in the report. Intersectoral action does not consist in bringing together ministers. It consists in work in the field by different actors to prepare and to gain knowledge of the reality and the interaction between social services and health services, for environmental and health services also. So it is the ideal place for this type of work. Universal primary health care for us has involved improvement because it changes the prior idea of having people that are giving primary health care focused on the territory. In other words, universal health care is based on the territory where they are operating. It is financed by taxes in Chile. There is a per capita financing. Therefore, there is an incentive for people to be registered, because with more people that are registered, more resources will be made available. In addition, the national emergency system in Chile recognized that the municipal level is the first level for preparedness to emergencies. So to incorporate primary health care in the emergency preparedness and response in the legal system for preparedness provides an integrated intersectoral view, not only for preparation but also response. The primary health care facilities, when built, we are trying to ensure that they are built with greater resilience to climate change, for instance, or as well as digital connectivity. They need to be a real hub so that in an emergency, one can go to them. For instance, if there's a drought, they might have water reserves or connectivity thanks to satellite connections. All of that strengthens resilience. The process that we are carrying out requires first registering all individuals in the facility so as to get to know them, plan, know their needs. One exercise that I could say is very difficult is to deliver responsibility. And that is one of the recommendations under the essential public health functions, to recognize local level intelligence and data. And that's important for resilience. Health sectors centralize information, centralize data, and deliver actions at the local level. But that cannot happen if you want a resilient system. It needs to be able to recognize local intelligence, to provide it with capabilities, and therefore be on an equal standing with local authorities who know their territory and draw up their own plans. And I think that is actually the most difficult step in these exercises, moving from a centralized system, and now we have had 40 years of decentralization of primary health care, but it still remains a complex exercise. All the outbreaks are born locally, as well as fires and floods. So to have a strong network for PHC means that if one area is impacted, they can move to a neighboring municipality that is lesser impact. We have strengthened capacities for primary health care, looked at the time schedules, operation in the fields, digital demand, continuity of care when there is under pressure. During the pandemic, this approach was put into practice. At first, one didn't want to go to primary health care as the first response area, and therefore it was concentrated because of fears given what was happening in Europe and the United States, where there was a lot of pressure on hospitals. So the national authorities tried to better prepare hospitals, and the epidemiologists and healthcare workers wanted to give more importance to PHC in order to strengthen public health measures. So when the vaccines started, then there was a change, because in the rollout of vaccines in my country was very speedy. And that is where we see the strength of primary health care. But it needs to be seen before. It's not only vaccines, but even before that, to understand how the essential public health functions are carried out by PHC. And if the first level has the capacity to detect and respond to emergencies, they don't scale up then. They can be better controlled. That is something that we learned, but it wasn't learned sufficiently when it comes to preparedness and first response to emergency situations. It's learned more in the strength and the coverage of primary health care in my country, which is extensive countrywide. We have a model based on people and the integration of the services, such as the information from the ministry looking at social development, working with the Ministry of Health, so that when the person receives care, you can see them integrally and sometimes guide them. Our bureaucracies have many rights for individuals, but it's difficult to understand them. The people don't understand them. And the healthcare is trying to take them on, but sometimes the people haven't resorted to their pensions that they have a right to, or housing facilities and other benefits. And this can only be done at the primary healthcare. It's impossible for a central system to do it. You need to bring it down to lower levels, because now we have reached such a level of development that tools are available locally. We have reinforced community participation. There cannot be any such participation if it's not at the local level, at the first level. Otherwise, it doesn't exist. Otherwise, it's a person. Nobody knows who selected or elected them, or who they're representing, or what group they belong to. But when it comes to primary care, working with the communities, you actually have a map of the actors. Each person has greater value in order to work in their community, and to reinforce the fact that we are in a system where the authorities are elected officials attaches greater value even for those who are responsible for primary health care. Fifthly, with universal primary health care, we have promoted digital transformation, the interoperability of records, the expansion or scale-up of telehealth, and the development of the first virtual health system. A law is currently under debate at Congress, and has early warning and intercoordination at different levels. So what we're actually seeing is a revolution of the medical system through technology. And primary care is where this revolution will take place, providing access to information technology, robotization, and AI. But we need to be capable of developing these skills at the primary or first level with more democracy in a more horizontal way for governance with the other levels of the healthcare system, recognizing the importance and intelligence of each levels in order to enact measures. Thank you.
Muchas gracias, Ministra Aguilera.
Thank you, Minister Aguilar, for sharing Chile's experience with us of this last year and your thoughts about your perspective. If we have more time, perhaps we can revisit the digital health issue, but we're going to forge ahead, and I invite Mr. Bernards.
From Belize, we heard from Chile, from Minister Aguilera, that one of the most important but challenging issues related to the implementation of the essential public health functions and its relationship, particularly at the, not so much at the central level, but at the community level. Belize is a small state which is highly exposed to climate shocks, and it represents the significant vulnerabilities that we see across the whole Caribbean in that regard. Politically, how do you see the integration of the essential public health functions within primary health care as a strategy that can really promote and strengthen resilience within the health sector and more broadly within society?
Thank you for the opportunity once again. And of course, indeed, Belize, as a small Caribbean nation and part of the Central American region, lives with that reality in terms of the climate shocks. We know we confront hurricanes, floods, and the rising seas that are now affecting us. And this can disrupt not just our economy, but our very sovereignty. And I think that for us, one of the things that we have said, that resilience is not a luxury, but it is survival. And that is why we see the integration of the essential public health functions into primary health care as a sovereign political strategy. In October of 2023, one of the steps we also took was to remove user fees from all primary and secondary care services, for the mere fact that we want to ensure that there's access to universal health care. And when we embed surveillance, preparedness, and health education and environmental health directly into our public health, primary health care, there are three things that I think had happened, and in our experience. One, we tend to reduce external dependency. Our communities, for example, as you know, becomes the first line of defense. And so we also, what we did in terms of ensuring that our community health workers, who are the first point of contact, we increased their stipend so that we could get more out of them as well. And so when we are able to then respond more quickly to outbreaks and disasters without waiting for outside help, and that requires us to have been able to train our people, and with the support of PAHO, we were able to do a lot of these things. I think that as well, in terms of when I mentioned about reducing external dependency, this also would it preserves autonomy in decision making within the country at the most critical moment. Secondly, when we ensure that we do these things, as I said, embed our surveillance and preparedness and health education and environmental health, the second thing I think we do is also strengthen social cohesion, because a health system that is rooted in primary health care, it builds trust. It builds trust between governments and citizens, and we recently rolled out our National Health Insurance Services, which focuses on primary health care. And that trust is the foundation, I believe, is the foundation of political stability. And And it becomes even more important when people are under stress from climate events. And the third thing when doing that, I believe that integration allows us, enables rapid and more efficient responses. And so our decentralized primary health care system can also maintain these essential services, even in the middle of a storm, so that we could ensure that there's continuity and protecting our people from secondary crises. I believe that the strategy used was also cost effective. It maximizes infrastructure, existing infrastructure, engaging our communities and partners and true partners, and ensuring that when external aid is needed, it is channeled effectively under national oversight. And so in Belize, our primary health care teams, doctors, nurses, our pharmacists and community health workers, they all work hand in hand with surveillance units to keep this system adaptive and inclusive. So for us, the integration of essential public health functions into the primary health care is not just about health. It is also about defining sovereignty, maintaining stability, and of course giving our people confidence that even under the hardest conditions, their government is present, prepared and capable. And that has been the priority of our government under Plan Belize 2.0, and the Prime Minister who, as the leader of the country, has also ensured that primary health care, health services is of priority in our country. And the budget for the last 2 years have been increased to ensure that we are able to keep our primary health care services at a level where we can offer better service to our Belizean people.
Thank you so much, Minister Bernard. You really highlight, I think, one of the key elements, which is the foundational support of community health workers and how they integrate within a system to ensure that resilience within primary health care. Agora, quero passar.
Now I'd like to give the floor to the Executive Secretary of Brazil, Dr. Adriano Massudo. Thank you for being here. Belize underscored the importance of the community health agents within the framework of the single health care system that has a network that is built on a family health strategy that has existed in Brazil for many years. I would like to ask a question. How is Brazil, within that context, building in early warning for health emergencies by way of keeping up primary health services and reducing wait times and referrals for specialized care, which is a priority that Brazil has had? Good afternoon. Thank you, James. I just wanted to greet you and greet all of the people on the panel. I would like to thank the World Bank, PAHO, and the members of the Lancet Commission that I had that I was privileged and honored to have taken part in. As Marcia said, now that it's been published, let's implement it. And I already kind of jumped the gun and started implementing it a bit sooner because in the health ministry, under Minister Padilha and prior minister and under President Lula, we started implementing it sooner. But on behalf of the Brazilian government, I would be remiss if I were not to mention the unacceptable restrictions of movement imposed by the host country of the host from the U.S. On our Minister of Health. Were it not for that, our Minister of Health of Brazil would be there in person at the Directing Council of PAHO. Despite that, I'd like to say that Brazil has a lot to celebrate. Regarding the 35 years that our single healthcare system has existed, we celebrated that anniversary just last week. And the family health strategy is intimately related to our overall health care, the SUS. That was our means of ensuring comprehensive universal access to health by the whole population in a country that has continental dimensions with stark regional differences. And so we wagered on a innovative system. We now have 35 years of experience working with multidisciplinary teams from the family health teams that offer care and public health actions. So that integration between the clinical approach and collective health for a population in a given geographic region is central and key for our being able to achieve or provide services to the population. And gradually we have made progress offering more specialized support to the family health teams through the support teams for family health. We've also made hefty investments in technology for health. 90% of our family health teams throughout Brazil, which is a huge country, more than 50,000 family health teams already have electronic health record system or access to that system. That's very important to ensure that our teams from the north to the south of our country can receive specialized support for public health actions or for specialized care with the backing of specialists. We have invested heavily through this network in the use of telehealth to offer support, doctor's visits, video doctor's visits, and to ensure that the family health teams are integrated with the health surveillance system so that early alerts can also be supportive in the overall response that is brought to bear, and also to address those cases that do need to be referred to other levels of care. Having been a Secretary of Health in the city of Curitiba, and the health secretary there, we rolled this system out 10 years ago, and the fact that we were able to refer from the basic healthcare system to specialized care and at a very high rate of 70%, lending greater efficiency to our healthcare system, how it's organized. Telehealth is a key aspect of this program. Now it is endowed with specialists. That was one of the priorities of President Lula, and that ushers in a whole host of innovations to make available, to organize, administer the specialized healthcare. All of the experience that we have garnered in basic health, primary health care, multi-disciplinary teams. Now we're taking that into our specialized health system so that we can overcome the fragmentation we have had and to ensure that we have a integrated healthcare system through networks and with proper organization. These are the different activities we are carrying out. And also the overall strengthening of the single healthcare system, SUS, the basic healthcare system, the strengthening of the overall integration of the healthcare system, offering specialized assistance where needed, as well as the health surveillance teams have also been bolstered, such that our overall healthcare system is best positioned and prepared to address the big challenges coming down the pike, such as climate change-related effects on health. So we find ourselves in an unprecedented way to be able to address. We have lost the sound, says the interpreter. Now, in the state of Pará in Brazil. Now, for the first time, seal the COP, Conference of Parties, is going to place front and center health amid all the big challenges that we face, working with PAHO and WHO, so that we can take this issue to that COP30 meeting in Pará. And so I'm very happy to be a part of this debate, and we will continue to push forward in this effort to implement everything that we have underscored in this report. Congratulations to all.
Muito obrigado, Dr. Massudo.
Thank you, Dr. Massudo. I would just say that Dr. Massudo was a member of this commission, Lancet Commission, within the Executive Secretariat of Specialized Healthcare. Now he is Executive Secretary of the Ministry of Health in Brazil. Thank you. Now, Dr. Santa Maria from Panama. Based on what we've heard regarding the importance of strategic partners who play a key role to support this process in our countries, you know that Panama signed in a partnership agreement to join this Alliance for Primary Health Care just yesterday with PAHO, with the IDB, and the World Bank. The Minister of Health of Panama was in attendance. Dr. Santa Maria, how do you see the role of this alliance in coordinating all these different activities that we've just heard about in countries to strengthen primary health care systems, and also more to ensure that the healthcare system be made that much more resilient? I thank you for that question. Regarding the pandemic, health and social protection now has been brought into other sectors, such as the sector of the economy, and this has strengthened the dialogue that the health sector has with other ministers in finance and health to overcome sectoral weakness to strengthen health overall. So this Alliance for Panama is going to be a key platform from which we can articulate and organize all the efforts, investments, and efforts that are made nationally and internationally. We appreciate and we see this alliance as a strategic approach in which we will bring together all the different technical, financial capacities of our partners, World Bank, Inter-American Development Bank, PAHO, and our healthcare system to ensure investments be complemented, and that would become a multiplying factor for our partnership, our pact. So this will enable us to order and coordinate investments based on a primary health care strengthening plan, or as a part of that, so that we can beef up foreign investments in keeping with our health care strategic goals, also based on the gaps we've identified regarding public health essential actions that need to be taken, and that coordinating all this calls for the marshalling of these foreign investments. Also, we have to be able to analyze the gaps and the critical areas, again, such that we can see how foreign investments will bring about greater social returns in the development of human resources and the services offered, and also making more vibrant and to strengthen our primary healthcare system. We have implemented using drones to transport samples. Telemedicine is done that way into the care given outside of our walls, and so this is going to bolster the resilience of our healthcare system, because if we invest in primary healthcare, we are investing in the resilience of healthcare systems, because we are strengthening our ability to respond, but doing it differently, based on the community, where or ensuring that there be timely access to quality healthcare services, and how that promotes innovation and knowledge transfer, ensuring that Panama can incorporate good practices, best practices, not just those that exist regionally, but worldwide. Recently, Panama launched the National Digital Transformation Strategy in Health with the technical financial support of the Pan American Health Organization, and also the Vice Chair of RECFES, of the essential public health functions, in which we are going to share best practices and experiences of countries regarding the plans of actions that we are implementing, so that we can address those gaps that we've identified, and ultimately strengthening primary health care and our resilience, the resilience of our healthcare system. So this alliance is a mechanism whereby we can articulate to render more effective, efficient, transparent our system, such that we can ensure that every dollar invested in health will strengthen primary health care and thereby also contribute to ensuring that our healthcare system be more equitable, sustainable, resilient to the benefit of our population. Thank you.
Muchas gracias y muchos.
Thank you very much, and I wish you the best of success in that consultancy advisory.
Questions, because we all need to be back in the main room in 20 minutes. So what I'd like to do now is to move to some closing remarks from our co-chairs of the Commission. First of all, from Christian Herrera, who's the Senior Health Specialist of the World Bank and has really been driving the work of the Commission, driving us all to the finalization, the publication of the work today. Christian, over to you.
Muchas gracias, James.
Thank you, James. Ministers, ladies and gentlemen, colleagues, friends.
Permítanme ser.
That may be a bit informal in my remarks. This has been a 2-year undertaking, quite a task. Working with Nestor, we got together and we came up with this idea. We spoke with Thaisa, and she quickly came on board. So, first and foremost, we want to thank Jaime, Tanya, for their steadfast support to this World Bank project. James, Ernesto, Natalia, I'm just naming a few. The ones, or many more have been a part of this, but I think everyone, our co-chair, Marcia, Sara, it's through you that this commission came together, and the secretariat that does the heavy lifting. Without a doubt, a number of them are probably listening in right now, connected. Adriano, as he said, he started as the academic co-chair and then went to the ministry, but he represents what we want to do right now, which is to take all of this action and translate into real practice. And so, urgency. The title of our commission speaks of the urgency. There is no time to waste because shocks and emergencies are happening right now. It's not that they're going to happen later on more and more. It's already happening more and more right now. And so given the manifold things that are happening everywhere, it's easy for this priority to be watered down. But we need to keep present the issue of urgency. Primary healthcare, resilience, they go hand in hand. If you strengthen primary healthcare, you strengthen resilience, and vice versa. Collaboration. This is a clear example of how collaboration can lead to more. Collaboration is being put to the test nowadays, called into question, and we think collaboration is precisely what will lead to more. This alliance is a case in point. We've got Alejandro from the IDB and the director, Dr. James, representing PAHO, the IDB, World Bank. The spirit of this collaboration, public-private collaboration, is also something that's very important, and it bears mentioning. we have to have the nonprofit organizations, the private sector organizations a part of this as well for the public good. Like Dr. Santa Maria said quickly, but the interface connection between finance ministries and health ministries, that interplay is key, but sometimes hard to come by. That's why we as a commission, we wanted to translate this data into economic numbers with which to facilitate this dialogue with the finance sector. So that cooperation is also very important. The last thing, we have to get to it, translate this into action. And all availing ourselves of the presence of all the authorities gathered in this room. This is done through you, public health ministers and public health systems. To make this work, we need you. And also regarding Lancet, for the monitoring to happen through the academic sector, if we launch this correctly or not, it's only through monitoring and follow-through that will ascertain that. Correct it. So, grateful to all of the different agencies, the bank and so forth, that are a part of this. So, from the World Bank, we thank you. We continue together in this undertaking.
Thank you very much, Christian, for those final remarks. And then over to Chair on Integrated Service Delivery from the Department of Health Systems Service here at PAHO as co-chair.
Gracias, James. Yo
2 minutes. Thank you, James. I think the overall context here and the recommendations made and the title itself, which says there's no more time. We can't put this off anymore. Beyond what progress might have been made in this or that country, it's urgent for all of us, and that's key. And something else I would like to say, and that is a part of the message in the report itself. The report also has built in something that's important for us to keep in mind, and I see it this way. It's going to be a long haul. It's no short-term, one-off series of actions. When we're talking about primary health care, we have to think about primary health care, as our director has said, that is modern, that can resolve issues and to coordinate not just healthcare systems, but becoming a resilient healthcare system, bringing all the parts together for that to happen. And that requires structural change. And going down that path will require not only resources, we have to ensure the sustainability, the lasting nature of this. That entails much complexity in the future. And as I see it, this also speaks to how we are going to navigate this journey, this path, to focus on how, not just on what. Just as Jaime has said, and the director himself, we have to undertake a political economy analysis, and not just think of the stumbling blocks along the way, but also think about the facilitators. So there are 3 dimensions we have to keep in mind. First, the institutions that have to be strong, that pave the way. Dr. Santa Maria and many of us stressed the essential public health functions. And when we speak of functions, we're also referring to EPHF, and we have to incorporate that as the key core element. In addition to that, there's something else. Goes without saying in this context, which has to do with the actors, not just the regional or global ones, but at the national and sub-national levels. And I'm referring to regional partners, partnerships, alliances that are rooted in the localities, that they be committed. But not just that, aligning all the interests of the different players involved, both public and private. By public, I'm referring to health care authorities and the state structure of health, but when I speak of private parties, I'm referring to the whole host of actors that make up civil society, and also building a narrative, which is what enables us to coordinate, as said priorly by Christian. I think when we think of narratives, I think we work toward this in the Commission. It's about clarifying some fundamental aspects, and I'm talking about primary health care. What does it mean? What is its role? The role of the relationship between primary health care that is stronger, the resilience of the healthcare system. When we speak of sustainability, it's not just sustained financing, but political institutional sustainability throughout the process. Networks of health services, barriers to health services. These were all the issues addressed in this report. I would like to wrap up. Unlike Christian, I'm not starting with the thanks. I'm wrapping up with the thanks. This was a rocky road somewhat, but also very exciting, challenging. And I would like to thank all of the technical teams, Lancet, Thaisa, who believed in us 2 years ago when we floated this proposal, all of the technical teams, and I would like to stress that because the idea came from the World Bank. So I thank the World Bank team, and I'm grateful for the fact that we have held these initial talks. Manuela, who's listening in, Tanya, Jaime, who have supported us in this process. In the case of PAHO, the whole structure that PAHO represents for us, James, the country offices, member states, played a fundamental role in this process because they didn't only share their experiences with us, but they made available to us many case studies in this process without which this would have been impossible. But in the case of PAHO and all of the technical teams, and Natalia Holton, who also was a co-chair, without whose participation none of this would have been possible. And of course, the IDB, which came in later on in the project, and what you said makes a lot more sense now. When I would say that I believe sincerely that in this project we weren't just a partnership, we were one single team, and as we move forward, that's how I envision it being. A cohesive team. If we didn't have this degree of integration, that what we've done thus far and what we hope to do would be impossible. Thank you.
Thank you very much, Ernesto. And that brings us to the end of this event. I really want to thank all our ministers present, our distinguished speakers, guests, the commissioners, teams from the World Bank, PAHO. It's been a wonderful event, and I think, as we've heard, this is not the end. This is the beginning. We will be beginning with now following on from this with a series of activities around diffusion, communication, and working with our countries around this report to see how we can now move forward to the implementation of those recommendations. Thank you very much and have a very good afternoon.